Hello, everyone, and thank you for joining us today. I'm Alicia Singh, Executive Director at Born Ontario, and it's a privilege to be here with all of such a dedicated group of professionals interested in advancing equity in Ontario. Born was established to collect, interpret, and securely share high-quality data that informs care, from system planning to individual care decisions. And as a prescribed registry under PHIPAA, we work across the continuum of care with many partners. This broad reach helps us reflect families' lived experiences and identify gaps and inequities in care. Prenatal Screening Ontario, or PSO, is a key part of our program. Originally focused on screening for genetic conditions like Down syndrome, the labs that are performing multiple marker screening, testing that's done by over 70% of birthing individuals in Ontario, have provided us some rare racial sociodemographic data. While imperfect, that data has helped us to start to apply a racial equity lens to the care and outcomes analysis we performed. Its limitations, however, highlight the need for more inclusive data that reflects Ontario's diverse population and the intersecting identities, including language spoken, newcomer status, race, housing and financial security, disability, and gender, among others. But today's effort to learn about the use of SD and SDH data goes beyond data collection. It's actually about connection. The N in BORN stands for network, and that's exactly what we are. A collaborative, province-wide network of programs, clinicians, researchers, policymakers, and data partners. And together we've made meaningful impacts in care and evidence generation. And as we continue using health equity to guide our improvements, we'll ask new and sometimes uncomfortable questions, uncover disparities, and build solutions that close these gaps in care, because the outcomes we seek must be attained by everyone. Equity isn't a side goal, it's central to our vision, best possible beginnings for lifelong health. And today's conversation and our accompanying survey are steps that we're taking to make sure our data and our systems and the way that we measure care and outcomes reflects that truth. We're aware that organizations are at different stages when it comes to health equity and collecting and using this data. And that's great. In fact, our own journey at Born has been long and nonlinear too. In 2012, we began with the launch of the Born Information System, or the BIS, a new platform that was going to bring together data from multiple existing sources and programs. We collected information about primary language and education level and a few other SDH items, but placed limited focus on completeness or capture at the time. Early in our journey, we also engaged with more than a dozen Indigenous health partners. And in these conversations, we listened for and heard how a registry can evolve to better reflect traditional models of care, support self-identification of Indigenous ancestry, and uphold Indigenous data governance principles. These insights help shape our thinking about how data can support and serve communities, not just systems. Internally, we've built and sustained a culture of reflection and psychological safety with our internal health equity advisory group. Formed in 2020, this multidisciplinary team helps us stay responsive to the diversity of the birthing population in Ontario. And we encourage our team to grow their understanding of health equity concepts, Indigenous sovereignty, reconciliation, and data governance, how to apply an equity lens to analyses, and strengthen the policies that guide our work. In 2021, we were pleased to strengthen the advice that we receive from people with lived experience and expertise outside our program to the creation of the External Health Equity Advisory Group. In 2021 and 2022, Born researchers published studies showing racial disparities in perinatal outcomes, even after controlling for other risk factors. These findings sparked new insights and hypotheses, and as we continue to examine outcomes across socioeconomic and sociodemographic lines, including recent work that we've done on postpartum mortality, we're increasingly aware of the limitations in the existing data. But publishing alone isn't going to be enough. We're increasingly aware we're going to have to be committed to bringing people together to understand why these differences exist and to measure the impact of the interventions. And we're actively building capacity internally to do that. Through recent work with our Ontario's pediatric diabetes education programs, we've learned from local teams how to safely and meaningfully collect social determinants data from children and youth. This work is shaped by thoughtful engagement with care teams and families and ensures that the process is respectful and secure. Early feedback from one center already using this data has shown us that it helps to tailor care in meaningful ways, reinforcing that even just the act of collecting and asking these questions and gathering this information can lead to better experience and outcomes. To improve outcomes for all families, though, we need to understand the broader context of their lives, not just the biology and the administrative data, but the social, economic, and cultural factors that shape health and life in Ontario. This represents a culture shift. It challenges us to move beyond the traditional approaches and recognize that access to care isn't equally distributed and there are numerous barriers to best outcomes. We must ask not only how many are receiving excellent care, but who is not and why. For clinicians, sociodemographic information, especially when safely self-disclosed, helps tailor care to the real and perceived risks and needs of patients. If we ask patients to share their food insecurity concerns, clinicians and care teams are better positioned to help them navigate available perinatal nutritional supports and resources, and allowing our care models to respond to and anticipate proactively and address issues that influence pregnancy outcomes, like low birth weight or high bleeding risk from anemia, with bleeding being the #1 cause of postpartum death, still in Ontario. For programs, both local and provincial, we can use SD and SDH data to allocate resources and tailor our programming based on our populations who come to our care settings. For example, if we see higher rates of preterm birth from preeclampsia among certain racialized groups or in specific neighborhoods experiencing higher levels of deprivation, those insights can drive our collaborations that tailor our outreach, our awareness campaigns, prenatal education, screening, and other services in collaboration with the community. It's that kind of data-driven coordination that's going to help care reach those who need it most and ways in which they can best access it. In multiple marker aneuploidy, or the fetal genetic screening I mentioned earlier, we actually use race to adjust for biomarker differences observed between populations. Our PSO program is doing a deep dive to understand how these adjustments continue to affect screening outcomes. But lab requisitions only tell part of the story. Richer intersectional data must come from elsewhere to help us better understand the differences driving the use of race, as race may only be a proxy for other underlying factors that affect screening performance more directly. Community organizations, for example, Indigenous health organizations or community-based parenting programs, all and some already do use SDOH data to ensure services are culturally relevant and supporting key health issues. As Ontario expanded its RSV protection program for infants last year, understanding who makes up that approximately 25% of children who remain unprotected after discharge from birth hospital and the social context that surrounds them and their families means that future seasons are going to help us tailor our approaches to better in partnership with clinicians and community to be responsive to the family's perspectives, values, and beliefs that may be affecting their participation in these programs. These kinds of approaches build trust and improve engagement with care, and we look forward to our work in partnership with ICES as we use our RSV data and additional sociodemographic information already collected about individuals, and including newcomer status that's available at ICES to give us better insights into the equity of that program. Researchers, including clinical and social science researchers, also use published insights to further explore disparities. Beyond the medical correlates, it can help to shed light on what some of the mechanisms, structural inequities, and discrimination may be at play in perinatal mortality and morbidity. And above all, we collect and use this data to drive accountability. Without it, inequities remain invisible, silent, poorly understood, and unaddressed. With an equity lens, we can track progress, identify gaps, and hold ourselves accountable, ensuring that equity isn't just a goal, but a measurable outcome. And the uses for our insights extend far beyond the health system. Many of you here today know that health is influenced by more than what occurs within our traditional healthcare settings. And where external factors are at play, like in many of the real-world examples I shared, it's our responsibility to raise them up as opportunities for improvement with government and others in position to better outcomes for life's very beginning. We've launched a survey to understand how practices and organizations across Ontario are engaging with their patients and clients to collect and use SDH data. And whether it's being asked and collected aligns with what was proposed in Ontario Health's guidance on collecting and using SD and SDH data that was published last summer. You've received a copy of this with your copy of your survey. This will inform our work ahead, and we thank Ontario Health for their leadership in making that resource available. Today, we're invited to join, and we're glad that you've joined us in this learning opportunity. Whether you've already completed the survey or just learning about it, we're glad you're here, and to hear from partners who are on the journey with us. Your survey responses will help us take a pulse on current activity and readiness across sectors, with the survey being shared with midwifery practice groups, birthing hospitals, and public health units across the province. Inform next steps in our own data collection, governance, and use at Born and PSO. Help us identify leaders and champions and early adopters who can support this peer learning and network building that we need to make important steps in these endeavors. And understand where support is needed to encourage the adoption of the leading practices for how we ask, collect, use, govern, and engage individuals and families in what we learn and how we can better support them. We hope it'll also fuel some partnerships. Beyond those who are presenting today, the aggregated results are going to be shared with all of you, our partners, and including the Equity, Inclusion, Diversity, and Anti-Racism Group at Ontario Health and the Provincial Council for Maternal and Child Health, who are both focused on this work too. And we hope that it also helps us explore meaningful use and perhaps novel and new data exchange options for prenatal, postpartum, and primary care settings. Some of the work we planned in the near future will use our unique registry authority at Born to directly impact care and outcomes with digital health solutions that reach individuals and families and their clinicians with the goal of improving the safety, care engagement, access to timely, personalized health information, and insights. These same digital tools, though, may be used to support private and well-governed sociodemographic data collection directly from individuals and families that can be used both in patient care and health system analyses. We've also asked questions in the survey to help us better understand how you or your practice might envision using SD and SDH data that patients or clients wish to share with you, but that comes from external sources.
Please join me in welcoming Manavi Handa. Manavi is a registered midwife in Ontario and practicing for almost 25 years. An award-winning midwife and activist, she's most noted for her impact on midwifery care for undocumented and uninsured immigrants. She's currently an associate professor at the Toronto Metropolitan University and practices at Reach Midwives. Manavi, thank you for being here and for sharing the work that you do.
Thank you so much for having me. It's a real pleasure to be here. Just to give you a bit of context, when I'm talking about the collection of SDOH data, I'm talking about it within the context of one of the places where I work, which is the non-insured walk-in clinic. This is a walk-in clinic that is run through Access Alliance Multicultural Health and Community Center, and Reach Midwives. We are the midwives who see all of the pregnant walk-in patients who come. And now we do a bit of expanded kind of reproductive health care also. So the context in which we're collecting data is actually data that's already been decided that the community health center wants to collect. Okay, we can go forward. So just talking a bit about how the data collection works. And I think this is really a place where technology could come in very handy. So people fill out this very large form, which we'll see in a minute, as part of their clinic registration process. So where they put their name and address and that date of birth information. They also fill out like a 2-page form that includes a lot of socio-demographic information. All clients are required to fill out the basic information, but most fill out the whole form. And so they get the form on intake, they have to fill it out. Then they give it to the admin person registers them, but probably doesn't put in all of the SDOH data. Then that client is seen at the walk-in clinic, but we have enough info for like a lab sticker or whatever we need. Later, another admin person puts in the rest of the SDOH data. So it's a pretty labor-intensive process. And in every step of that, one is sometimes there are interpreters available, but often there aren't. And English is not the first language for many people, and many don't speak English at all, certainly don't write English. And so filling out the form, if you speak English, probably would take a good 10 to 15 minutes, 20 if you're proficient in English, but not as your first language. And at every time the data is input, and we've just finished a 10-year data collection, which is why I can share some of this information. Every time it's input, there's more chance of error from what the original form said. So I think that's kind of an important thing to think about. And I would say most people fill out the form. Okay, we can go to the next slide. So what are the problems? As I said, English is a big issue. There's often an on-site interpreter for a few hours of the clinic, but they're more needed for actual clinic appointments. So they might be in the registration area available to help. I don't know if people know why the data is collected. And so I was thinking, like, St. Mike's years ago had this program called We Ask Because We Care. And I was thinking it might be helpful when collecting SDOH data to kind of use some kind of familiar terminology so people realize it's because you want to improve their experience that you're collecting the data. It's not punitive. And I say that especially because I work in a world of people who are undocumented. I think with tech, it could be easily fixable. Like I don't see why clients don't just get a tablet and we use some kind of AI translation. Like it just seems like it would be simpler and have less error. And so that's just kind of a lesson that I've been thinking about. I mean, really, I think the idea of tablets would seem expensive until you realize how much admin time goes into the collection of SDOH data. And to be honest, this is an organization very committed to the social determinants of health, but I can see why, if that's not your aim, it would be considered really cumbersome. Okay, next slide. So they do pretty robust data collection. So there's 6 categories: insurance, socioeconomic, language, background, disability, and well-being. And I'll go into some of those in a little bit more detail. So the next slide. So gender identity, where I would say here with gender identity and sexual orientation, both boxes on the left, the language is really dated. And I would say that that is one of the challenges, I would say, is as we understand the complexities of identity and intersectionality, how do we keep up as we evolve in our thinking so that things don't become dated really quickly? And I think this is an ongoing challenge as language changes and norms change and our understanding of experience changes. So you'll see under sexual orientation, there are kind of many fewer terms than what I think we would use now. So that I think is a really good example of an area where things get dated quite quickly. Going to the education, we ourselves were not really sure what university, there's a category, there's university, bachelor's, and college, and we just realized that in lots of places in the world, university is called college, and so it's a bit of a confusing terminology, but otherwise I think that one's pretty robust. Certainly what we found in our data was, and we've just done, like, this is barely looking at our data, we've just collected it, is realizing that there weren't a lot of surprises, like demographics that we know tend to have lower levels of education. That was reflected in who we saw also. Okay, next slide. I'm trying to go fast too, because I know we have other people. So income, I was surprised initially that we started so low. And I would say, like, I was like 0 to 14,999 for a household. Like, is that a thing? And yet, I would say 90% of our clients reported a household income of less than $20,000. Only one out of 1,350 charts had an income of over $60,000. Everyone over $25,000 were permanent residents. And that speaks a bit to our system and how permanent residents have to have more economic stability in order to get their papers. It's also, you know, obviously there's the question of, are people honest in this or not? I don't know why they would be dishonest, because we have nothing to do with any financial kind of assistance that anybody could get. But I do recognize that we're also talking about a population that's very precariously employed. And so is household income really accurate? Definitely, I think homeless status, I think the language needs to be changed, but I think we also need to consider precariously housed people. And we didn't anywhere in here collect food security. So I think that would be something that would be really important also. Household composition. Now, obviously, there are a lot of different options, but I think they do a pretty good job of collecting kind of the different versions that households are made up with. Okay, we can go to the next slide. So definitely, and this is where especially around language and our understanding of intersectionality is important. There's a lot of Indigenous focused language that I would say is missing. So they didn't include Inuit. They didn't include any kind of Indigenous groups from Central or South America. People from Australia, Pacific Islanders, Eritrea, like so. And I think one of the lacking places is that there's a place for mixed heritage, but there's nowhere to identify with more than one thing. So there are people who identify as Métis and Black, but we just say you're mixed. We don't let people kind of pick multiple things, if that makes sense, which I think in our world would make much more sense if people could choose more than one category. The definitions were very Western, and I found it interesting. I mean, we have a fair number of people from Central and South America because you can get here from those parts of the world. But it was interesting to me, for example, Brazil, which is kind of known as, you know, one of the areas in the world that has lots of cultural mixing. The number of people who would write Brazil or Brazilian with exclamation marks as a almost like a protest to the categories that we had. And so I thought that was interesting. Okay, we can go to the next one. Disability, I mean, some people did write pregnancy under others, so that was kind of interesting that, you know, people saw pregnancy as disability. It was very interesting to me, and I think it was great that we asked about sense of belonging to community, and I think that, you know, I really like that wording. And it really varied from very weak to very strong, and that might have to do with what kind of heritage groups people are part of. But what I also thought was really interesting is they asked about this people's self-assessment of their physical health and their mental health. And the vast majority said good or very, very good or excellent to both. And I think in some ways that probably speaks to the healthy immigrant effect a little bit. Like, we know that if you're young, you're healthy enough to get pregnant, so you're presenting with pregnancy already, that says a good amount about your health status in a way. And so, you know, we know there's an idea that immigrants when they first come tend to be healthier. And so is this more common earlier on? And it would be interesting to see, like, if we had people fill this out over time again, like 5 years later, would it change? Like, we don't do that, but that would be really interesting. Okay, next slide, and then I'm almost done. So the surprises, I would say, is how many people fill out the form. I certainly think I would be more impatient with it, especially if I didn't understand the language that it was written in. One of the kind of interesting surprises is there is this new trend that we're seeing that really became apparent in our research of Mexico and Brazil are like the capitals of the world in terms of cesarean section rates, especially within the private sector, but now also in the public sectors. And there's this new trend, and I always think where cesarean's most common, these trends start but spread pretty quickly, where women are being cut from their umbilicus to their pubic bone in a straight line instead of what we call a low bikini cut. And they'll get the low bikini cut. It's called the cosmetic cut now, if they have money to pay for it. So not only are they being horrifically scarred, but once you are cut that way externally, we don't know how your uterus is cut. And that puts you in a totally different risk category around where you might want to decide to give birth and how you might want to decide to give birth. And so it's putting all of these, like a good proportion of our uninsured clientele in a higher risk category automatically. Just a reminder, I mean, I think the level of poverty was a surprise in some ways, maybe not in others. I think that was all. Yeah, those were the main points. I think there might be one more slide. Oh, so I mean, we've just done this 10-year data collection. So how we've used the data and what's happened in the past. So definitely the community health center has used it to develop targeted programs. So one of their big programs is something called Health with Dignity, with the understanding that marginalized communities often are not treated well in our healthcare system. I certainly think for Reach Midwives, we could utilize the data to inform programs like prenatal classes in Spanish and Portuguese in particular, vaginal birth after cesarean classes, so that people who've had these cesareans can decide for themselves and help determine for themselves what kind of incision they think they might have had. There's kind of a series of questions you can ask that make it quite clear. And maybe even a session or some kind of information to clients about hospital payments and how that works, so people realize every time they interact with the hospital system, they'll get a bill. And then just I think if we could implement something, it would be tablets for people to be able to fill out the information.
Aideen Reynolds is a knowledge exchange specialist with Ottawa Public Health. She has over 20 years of experience working in health equity in academic, community-based, and public health settings. Her current role focuses on advancing the collection and use of SDD within OPH and contributing to standardizing SDD collection among local, regional, and provincial health system partners. She's accompanied by Geneviève Mosher, who is a nursing project officer for Ottawa Public Health with 20 years of dedicated nursing experience in maternal, infant, and family health. Her extensive expertise encompasses both hospital and community health settings, where she has made significant contribution to the Healthy Babies, Healthy Children program. In her current role, she plays an important part in supporting sociodemographic data collection aimed at enhancing client-facing services for families with the Healthy Growth and Development Program by effectively addressing barriers. Aideen and Geneviève, thank you for being here.
Thank you so much, Pascale. And thank you for the invitation to share our experience with all of you today. Before we get into the presentation, I just want to start by acknowledging the clients who are trusting OPH with their sociodemographic information, and also want to echo and acknowledge OPH's Healthy Growth and Development team for their leadership in this work at OPH. They really are leading the charge at our organization, so just want to acknowledge them. And I also want to thank Pascale and Bourne for the land acknowledgement. Geneviève and myself are joining from Ottawa, which is located on unceded Algonquin territory, Anishinaabe territory. And I want you to know that OPH is collecting SDD on behalf of Indigenous communities in Ottawa, and we're committed to following OCAP and other Indigenous data governance principles that keep ownership and control of the data with the community. As far as an overview, so what we'll share with you today, we'll talk a little bit about the current environment as far as enablers and frameworks for STD collection and use. We'll talk about the STD journey at OPH at a very high level, and then Geneviève's going to walk us through sort of how we've rolled this out in the Healthy Babies, Healthy Children program, and we'll wrap up with some lessons learned and what things to share with the group here today. So listening to you earlier, Pascale and Alicia, and you've made mention of some of these documents already and this guidance, but in the public health context, I'm not sure how many public health colleagues we have here today, but monitoring health inequities is foundational to public health. So you see there on the left, that's a model from the National Collaborating Centers for Determinants of Health. And it shows public health roles that include assessing and reporting inequities in populations. So these public health roles and the focus on health equity are also reflected in the Ontario Public Health Standards, seen there on the right. And these outline the requirements and minimum expectations for public health units in Ontario. So there's very clear guidance sort of that suggests the need for this work. Where it gets difficult is having the systems to actually capture the information. So there's an expectation that we are monitoring, assessing and monitoring and addressing inequities, but having the systems to actually do that are sort of where it gets challenging and where we're pushing and trying to advance the work. So just a little bit more here in terms of background, we see alignment with guidance from Ontario's healthcare sector. And so there was already mention of this health equity, inclusion, diversity, and an anti-racism framework, where we clearly see there on the middle circle, that upper left puzzle piece, collecting equity data is a key area of action. And then on the right, this has also already been mentioned, but the guidance from Ontario Health for the collection and use of STD for equity analytics. So there's very clear alignment with kind of the direction that the province is going and other leaders. As far as our journey, we had actually started piloting STD collection before the pandemic. But it actually got a real boost during the pandemic when health units in Ontario were mandated to collect from people who were diagnosed with COVID-19. And I don't need to share with this group, I'm sure everybody's aware that when we did that, we found inequities. So we did see that COVID-19 was impacting disproportionately certain members of the community. So then coming out of COVID, we're looking to build on this work. We launched a policy for STD collection and use that was intended to communicate a clear commitment to this work internally and externally with partners. The image on the right is our conceptual framework that emphasizes the importance of community and relationships throughout all aspects of this work, starting from deciding whether STD is even an appropriate tool or whether it's needed, right through analysis, disclosure, and getting to being actually able to share and use the data with partners. So just continuing to center the community voice there. And so in that way, we want to ensure that we're honoring principles of data governance, particularly with Indigenous communities, as well as with Black and other communities in Ottawa. And this requires that meaningful, ongoing engagement with community. So continuing to build internal and external support, our strategic plan 2023 to 2027 has a specific objective to advance STD collection and use in front-facing services. So that's been very helpful just internally to set that expectation. Related to that, we developed a resource page for employees to learn more about STD collection and to support implementation of that new STD policy that we were rolling out. And then we also produced public-facing resources, such as the brochure you see there on the right of the screen, to explain to clients, why we're asking for this information, to help with that trust-building piece that happens between the provider and client. This is a busy slide, but basically this table gives you an overview of where and how we're currently collecting. The program areas are listed down the left-hand side of the left-hand column there, and the rows are color-coded to depict the status. So the top 4 orange rows reflect work that is now finished, where we've finished collecting, we've analyzed, and that's considered complete. The green lines or rows are actively collecting, and the last 2 yellow rows are in planning stages, and we do have a few other areas that are in planning stages. The how column shows the method of collection. So we work with teams to adapt to their unique workflows and implementation context, and to learn from the teams what information the program wants to collect and for what purpose. And so while the method of collection might vary from one team to the other in terms of the process or the procedure, we do strive to ask for the information in a consistent way, as recommended, as our policy recommends. The question wording and response options are consistent and informed by best available evidence. So such as that we ask because we care work in Toronto, but also CIHI, also the Ontario Health Guidelines as well. So we're anchoring in those best practice guidance documents. When we talk about this work, we often use these 2 bigger buckets. So there's on the left, the orange bucket is everything that goes into thinking about whether we're going to collect SDD, planning, to starting to collect. And then once we started collecting, then the gray box or bucket is all the work related to monitoring completion, looking at data quality improvement, analysis, and then finally being able to share and engage partners, and hopefully engaging partners throughout, which is why we have that box in the middle as a reminder that we should be engaging community in sort of across. And if you remember the framework, across those 4 stages of collecting through to analysis and use. The bidirectional arrow also suggests that it's not linear, and there's often we're going back and forth, like it's not a 1, 2, 3, 4, 5, 6, and there's often we're going, we might have already started collecting and we're looking at completion and noticing that the data is not very complete. Then we have to go back and revisit the procedure and perhaps make some amendments or add something. Some other supports. So that's just to suggest that it is fluid. It's not a one-directional kind of process. So I'm going to hand it to Jen to talk about SED collection in the HPHC program. Go ahead, Jen.
Thank you, Aideen. Thank you. So the next slide, please. Perfect. So now we'll take a closer look at how our Healthy Babies, Healthy Children program is doing, and it is collecting this information. So to start, the referrals are usually received either from our hospitals, so either from hospital staff or from our hospital liaison nurses from public health who are in hospitals every day, or they are received from our community partners. And families are usually screened during using the Born screening tool at the bedside when they are in the hospital. And one of the ones are identified with needing additional needs are referred to our Healthy Babies, Healthy Children home visiting program. So during the first home visit, families will receive an in-depth assessment and the SED is completed. And families with a positive IDA will be offered the long-term home visiting program. Next slide, please. So the SED was started with our program in late 2022. So it is voluntary and with the informed consent from the clients. An Ottawa public health nurse or a family home visitor will ask the SED directly from the client during a home visit. And this can be either a parent or a caregiver. And we aim to collect within the first 4 visits, but ideally the first or second visit is the best scenario. The data is collected and entered in a secure Microsoft web form with the family file number. So there's no other identifiers. There's no client name or date of birth. And there's an option to collect this information during the home visit on paper and then to transfer later in the computer in the web form. So as a visual aid tool, we have created this form in different languages. So at this time, it's available in Arabic, Simple Chinese, Spanish, Hindi, and French and English. So sometimes it is helpful for clients to kind of look at the form in a different language and follow along with the questions. And you'll see in the slide on the right, there's 12 fields that we are currently collecting. For the last, if you see the last two at the bottom, you'll notice that our team is now requesting information on for immigrant status, and depending on other services that they may need. For example, if they don't have access to a regular care provider, we are able to support with this if we know this information. Next slide, please. So since we started collecting, 50% of our clients have been involved or invited to provide an SDD. And of those who were asked, 91% consented. So we're getting some great interest in receiving this the SDD. And at a high level, these findings are really validating what the nurses are seeing in the front lines, which is an overrepresentation of new immigrants, the need for other languages other than English or French. There's a lot of housing instability and shelter use at the moment, and there is a need for mental health support. And also, many do not have a healthcare provider, so which is a key determinant of health. So we are seeing this information, and this will help to improve the situation down the road. Next slide, please. So to get to a point of being able to use and share this data with the community, we planned a community dialogue in October of 2024. And this was to find out how can this information and data be used and who would benefit from having this information and who needs to know, and to hear about any risks there might be to sharing this information. So we had more than 30 participants included in the meeting, and organizations who work with new and expecting parents, and we included some HBAC clients as part of this community dialogue. And we shared a summary of our findings and talked about how OPH is using SED, which including things such as increasing the diversity of languages spoken by our staff, prioritizing mental health and training for staff to be able to cater to the needs of our clients, engaging partners. So, for example, housing and shelter use, so we're able to collaborate with our Ottawa housing partners in order to help the situation. We're also able to liaise with local OHTs to attach people to primary care providers where possible. And also we're able to tailor support to clients who are immigrants. So I'll pass it back to you, Aideen, to continue the presentation.
Thanks, Geneviève. So just to wrap up, a few things we've learned. Success requires a slow and steady approach, and particularly the way we're working, where we're tailoring collection by team, it is very resource intensive. So I could really relate to what the previous presenter was talking about with the resource intensive, but particularly when we're kind of tailoring by team or by interaction. Depending on the program and what questions you want to answer, SDD may not be needed or may not be the right tool. So there may be other equity data that can answer the questions that the program has or that the organization has. We've learned that teams need time and tools to feel comfortable asking for SDD, and training helps to build provider comfort and confidence to know how to respond to any questions that the clients have about this initiative. And then, of course, establishing comfort also applies to clients. They need to feel safe and understand why we're collecting this information and how it will be used. So informed consent is key so that clients understand they may choose to decline or prefer not to answer, and that it will not affect their care. That is so important. Our experience has been that when SDD are collected and analyzed, inequities are identified. And with that analysis piece, we need to handle these data with care. Community needs to inform and control how we use and share the data in ways that advance health equity and do not harm communities. So particularly, in all work, but public health work, I mean, we work with, infectious diseases, and we really need to pay attention to what we're finding in the data, and really, we do not want to cause harm to communities. So how do they want to tell their story? What's their experience? And it is their data to share. So the importance of ongoing engagement. Oh, this is key. The importance of ongoing engagement with teams to encourage collection. So they like the teams that are doing the collecting, like hearing about how the data is being used in programming and decision making. So conversations with the people who are actually collecting the data creates buy-in and ultimately yields better data. So for example, my colleague and I have been invited to the Healthy Growth and Development team meeting annually, where we go and we talk about completion, like how complete is the data and what are we finding? And the team is the one that said, can we ask about primary care providers? Can we ask about immigration status? And the most recent one is, and we're working on a question about food security. So I agree with the previous presenter, but the team is actually asking for this information. So it just shows us what that how that engagement can really build that buy-in and garner interest in this work. So thanks. I think I've got a couple more slides, 2 more slides. Okay. In terms of lessons learned also, OPH co-led a Public Health Ontario funded LDCP project, so a locally driven collaborative project with Peel Public Health and Upstream Lab. And this was to document the public health experience collecting STD through COVID-19. And what we see is that the findings reflect the common themes similar to what we've shared today. So this, you're going to see, if you look at what was found with our peer health units, it's very similar to what we've shared today. And you can look at those links on your own time. And then finally, just a note about data systems. Back in 2022, OPH led an ad hoc working group of 9 public health units to identify a standardized set of STD fields to recommend to the province for inclusion in database systems. We reviewed existing tools and best practices and reached an agreement on 14 STD constructs to recommend to the province for inclusion in public health reporting databases. So AFIO, the Association of Public Health Epidemiologists of Ontario, and ALPHA, the Association of Public Health Agencies, endorsed the recommendation. And this visual above is a letter that was sent to the Ministry of Health asking for these standard, the inclusion of these standard SDD in data systems. And I guess what we just want to say is we're delighted that Born is moving kind of in this direction and advocating for kind of better data and systems that will collect this data, and looking to capture this important information from our clients, our people. And that's it. Thank you so much.
Please join me in welcoming Shâdé Chatrath. Shâdé is also known as the baby catcher. She's a registered midwife who works at West End Midwife in the GTA and surrounding areas for the last 15 years. She started her journey supporting people with their health and wellness goals. However, she loves to tell people that the seed God planted in her was to become a registered midwife. She recently helped to create a division of midwifery at William Osler Health Center and eventually was appointed the division head of midwifery, where she works endlessly with an amazing team of midwives to integrate midwifery at a hospital level. She also is the co-chair of the Black Excellence Group at Osler, where she focuses on supporting and celebrating Black excellence year-round. Her work and life experience led her on a recent journey to start a nonprofit registered charity called Black Reproductive Empowerment and Transparent Health Equity, or BREATHE Midwives. The goal of this is to decrease the disparity for Black birthing individuals, their infants, and family who face and improve their experience of birthing and birthing outcome through free access to care, services, programs, and resources. Shâdé, thank you very much for being here today.
Thank you so much for the invitation and all the amazing work that you guys have done. And I'm really honored to be here. I'm just going to share my presentation. So as introduced, we are BREATHE Midwives, which stands for Black Reproductive Empowerment and Transparent Health Equity. So we use the word breathe because breathing is known to help improve health. There's been a lot of things in the media, if you guys remember, with George Floyd about he couldn't breathe. So we thought the name was really fitting. And so that's a little bit about us. So in terms of, before I kind of go into kind of all the social determinant of health, how we kind of use it, I just wanted to talk about our breath initiative. This really is the key foundation of how we serve the community, how we run our programs, how we advocate for people, and how we collect data. So there are 6 key elements that really focus on these things. And one of them is Black. So we're really putting Black individuals at the forefront. We're kind of listening to them, using their voices to kind of collect data and then make programs and services. The other one is resilience. So how people have to fight to be heard, to be advocated, but also to celebrate the strength that they have as well. Empowerment, we want everyone to feel empowered. So the data that we're collecting, we want to be able to use it and utilize it and use empowerment. Advocacy. So we're trying to take this information, the programs, and advocate for the people that come and seek our care. Trust is a big one. So whatever we're doing, whatever we're collecting, whatever we're asking, we want there to be trust. We want people to know. And healing. There's just a lot of generational scars, a lot of mistrust. And so we're kind of healing from all of those different things. So I just wanted to kind of give like a little bit of a synopsis into kind of like what we do. So our community is amazing. It's diverse, lots of energy. And so I just wanted to kind of share some of the data that we do collect. So we have a vast range of different individuals that kind of seek our care, and it spans from youth or young adults into seasoned adults, as I like to say. And the majority of the people are ranging between 18 to 44. We do hope by collecting this and trying to expand and understand our community that we'll be able to expand a little bit more beyond this age group. As we said, we are a Black focus, but that doesn't mean that we do not have allyships with other individuals. And we have found that people still come to us, still reach out to us. And so while majority of the individuals that we do support are Black, we do get other individuals. The tendency tends to be South Asian as well as Hispanic individuals that come to us. Majority of the individuals that do seek our care tend to be uninsured. And so it is no surprise, as a registered charity, one of our mandate is that we wanted to be free access to care. We didn't want to have any barriers. And so it was really interesting to see the majority of the people that do come to us. A lot of these individuals are immigrants, refugees, asylum seekers. They need access to care. They have been turned away from other people because of the criteria they don't meet. Some of the other data that we do collect is address, to kind of figure out like where are people coming from. So we're located in Etobicoke, but we find that we're getting people from everywhere. It's very interesting how people talk and they find access when it's needed. We've had people contact us from Ottawa. We've had people who've driven from Barrie to come to us, and even have moved into a friend of a friend's house just to be able to be closer to have access to care. We collect data on gender. We also collect on disability, the types of caregivers that are referred to, how many people are actually getting accepted into care. So the way we work kind of on a drop-in, walk-in basis. There's no attachment. So what we do is we try to refer to other care providers for longer term. But if we can't get people in, they're more than welcome to come. So we're collecting the data, how many people we make referrals for, and they actually get accepted, and then mental health. So this little chart here just kind of shows most of the people that seek our care come from the GTA area. 100% at this point in time do identify as female. Most people get into OB care, and what we have found is based on the structure of how midwifery practices work. So they are allocated specific funding amount of people. So sometimes it's a little harder to get into care. So that was very interesting to find from the data. And we find that about 87% of the people are getting into care. As we know, there's a shortage of healthcare providers. So everyone isn't going to be able to get into care somewhere. And no surprise that a lot of people do experience depression. And so that has really shaped the type of programs that we offer for people. So data collection, when and how we collect it. And so there are three kind of key moments that we collect our data. So one is when people check in for prenatal, postpartum, and infant checkups. And so I just have a screenshot here of what that might look like. We have it also when people are registering for some of our programs. So we have a home visitor community program where we go either into the hospital or the home to see people and connect with them. We have like a mental health program. So we're collecting a lot of data to just make sure that we are able to support them in these programs. And then the last time where we're really collecting is to get feedback about the services and programs and what they would like to see from us. So there are various ways that we do collect and have collected the data. So we've used something called JotForm, for example. So it's kind of a survey questionnaire platform. We eventually upgraded to HIPAA to be compliant, and just because we were finding we were going to need more information that was personal, and we wanted to make sure that this information was safe. We also collect information using our EMR, because as we said, we do some care for our individuals. They're signing waivers, and so we have a cloud-based server. We use something called OceanMD. This is what collects kind of our intake to get the data that we then use to provide access to care. We've used Adobe Signform as well. Depending on the individual's knowledge language, we did find that sometimes it could be a little tricky for them to utilize. Initially, before we got cloud database, as a nonprofit, we're dependent on funding from the community. We used something called Singh, which was a cloud database secure system to be able to store some information. And we've also used something called Miato. So here I have some screenshots. I'll go slowly just so you can kind of see. These are some of the questions and the data that we're actually collecting. And so here we're asking in terms of ethnicity and race. So we try to be as detailed as possible without overwhelming, because we did find that the more information that we had, that it could be a little overwhelming for people, especially again, if English was not their first language. Here, for example, we do have questions about mental health. As you saw from the data, a lot of people do experience that, depression. Whether they call it depression or not is a whole different thing. But we did want to get into different questions that could lead to anxiety or depression. Some of the things that we did try to do, and this is OceanMD, and one of the things that I do like about it, if you can kind of see here, this little sidebar, you see some things that are kind of highlighted in red. So depending on the response the individual has, you can set up the questions and the response to be certain colors to have flags. So for example, if someone identify as Black, African, or Caribbean, or Indigenous, it would be red. But if they were another racialized group, it would be maybe like an orange. So there's different ways that you can kind of highlight things that you want to make sure you identify so that you can provide better access and services to people. Here you can see we have a good array of different questions, like people are coming sometimes for postpartum, pregnancy loss, maybe it's about just sexual health and reproductive questions, mental health, feeding support, education. And so depending on what they answer, another bunch of questions would come, again, just to make sure that we are providing as much care based on the voices of the individuals who are seeking. Here's an example of the privacy, so the HIPAA compliance. So They will fill it out. When we get it, we don't see all the answers. And then what happens is that we do have to log in and then sign in with a password to be able to access the information, making sure, again, that it is very secure. In terms of program collection, we ask specific questions about the type of programs. We collect information about how many times they're actually utilizing our services too. So again, if someone was able to get into care, then they might have used our services 1 or 2 times. But if they weren't able to get into care anywhere, they might have used our service 3 to 5 times, for example. We also ask about culturally affirming care. How is that important for them to receive? So how did collecting SDH data help us? So it really helped us identify at-risk populations. So again, collecting this data helped us to recognize individuals and families who may need the extra support and making sure that they weren't falling through the cracks. It enabled target intervention. So like I said, we were able to collect more specific data, really design and change some of our programs, to make sure that they had the better outcomes. And then it helped us to inform policy and care. So it guided our clinical care, our policy decision, and it really helped us to advocate for healthier communities. So as some of you might already know from the Senate subcommittee, socioeconomic factors account for 50% of health outcomes. Healthcare accounts for about 25% of health outcomes. Genetics accounts for 15% health outcomes, and physical environment accounts for 10%. So these are really important factors for us to just remember that it's not just going to be one thing. There are different things, but socioeconomic was a really huge thing for us. So how are we taking action? I want to be mindful of time. So we're taking action. We're creating services and programs for Black individuals using a social justice and culturally affirming framework with health equity at the forefront. And so this really has led us to have access to care, so offering programs that are accessible and giving them education and bringing awareness to change the system when it comes to Black reproductive, sexual, birthing, and infant health. It helped us to really remove some barriers, so addressing and removing barriers that make access to healthcare difficult. So instead of just putting like a Band-Aid solution, right? So sometimes we'll create programs, but how are people getting there? How are people, accessing those programs, utilizing? Does it really work for them? And then it really allowed us to use the concept of our community. So you take the concept, it takes a village to support, nurture, and build community to support older and future generations. And if I still have a little bit of time, I would love to still share stories. But in general, the stories, it just really helped us to improve outcomes, really integrating the social determinant of health data led to earlier interventions, healthier birth, and several families in our care. It really allowed us to collaborate with local organizations, provide essential resources, using prenatal postpartum transitions for new families. And it really helped us for voices from the fields. Families and care providers reported feeling more empowered and supported when we used the social determinant of health as part of their care journey. And one story that someone did give us permission to share. So it's only been a year since we started our life here. Having a baby was never in our plans so soon. And without a health card, the thought of pregnancy care felt overwhelming. Each day we worried about how we would manage the cost and find proper care. Then, like a blessing, we found Breathing Midwives. They welcomed us with open hearts, listened to our fears, and guided us with compassion. They helped us find midwives who are now taking care of my wife without asking for anything in return. In that moment, we realized it's not just medical care they gave us, but love, hope, and a sense of family when we needed it the most. To the trust and the midwives who stood by us, we are forever thankful for your kindness. So I think it was just a good way to just kind of summarize some of the ways that, again, social determinants of health really allowed us to really give proper care for people, specifically for what they needed. So some of the challenges that we do face or have come across is privacy concerns. So we've been really working hard to make sure that the data that we do collect is private. Some people are really hesitant. Sometimes they don't want to take our care just yet until they do research, until they really know. Some are, afraid of immigration. We found that there's different inconsistent methods. So it depends on the tools that we use. Some would do it one way, some were a little bit easier to navigate, as I mentioned earlier. Lack of standardization with some of the tools. Again, some were a little bit different depending on the community that you were working with, the organization. And then there's limited routine collection. So not everyone is collecting data. So we were collecting some, other people weren't. And so, you know, that can be a little bit of a barrier. How we can make improvements. Standardized screening. So just make sure that the tools are standardized across the board. Staff training is one of the things that we found. Community collaboration, and then personalized care plans as well. Next steps for us, diving deeper. So we want to dive deeper into access to care, like how far are people traveling, how long it takes them, you know, what is the mode of transportation. We want to explore culture a little bit. It's very complex. You know, you can have two individuals who identify as African, but that doesn't mean anything. We wanted to look a little bit more at social safety nets. So what policies, programs are being utilized by individuals to prevent negative outcomes. We wanted to look at self-care and wellness a little bit more. We found that you can't really always use the word mental health. That's a very big stigma. And so we actually had to change the name of some of our programs because mental health, you don't have mental health issues. You don't have depression in a lot of the Black communities, for example. We want to figure out trust in the system. So one thing that we couldn't figure out how to collect was a person who left one caregiver to come to us or to go to another caregiver because they didn't feel safe. They didn't feel like they trusted that. So there was just no way to kind of capture that or report that. And then collaboration. So how the different collaborations between various programs and professional organizations play a role. So moving forward, the last slide, there really is no point in collecting data if we're not going to listen. Data is only valuable if it informs decision, action, and insight. Collecting data without analyzing it, understanding it, or acting on it renders the efforts wasteful and ineffective. There's no point in collecting data if we're not going to use it. Don't just talk the talk, but let's walk the walk. Funding partnerships and collaborations are also important to make this work happen. Thank you.
Join me in welcoming Dr. Crystal Clark. Dr. Clark is an internationally recognized psychiatrist in women's mental health. She is the Canada Research Chair in Reproductive Mental Health, Associate Professor in the Department of Psychiatry at the University of Toronto, and Associate Head of Research at Women's College Hospital. Dr. Clark specializes in mood and anxiety disorders, specifically across the reproductive lifespan from menstruation to peri and postmenopause. Her research aims to address gaps in psychiatric health care through development of identification and prevention strategies for marginalized populations in psychiatry, including visible minorities and those with severe mental illness. To this aim, her work focuses on birthing people who are of African descent, as well as perinatal people with bipolar disorder. Dr. Clark is the past president of Marseille of North America, an organization dedicated to advancing perinatal mental health care, and she serves on the board of directors of Marseille International. She has been a contributor to large initiatives in the US and Canada to improve perinatal mental health in North America. Her research has been funded to the National Institutes by the National Institutes of Health. Dr. Clark, thank you very much for sharing the work you're doing with us today and for being here today to talk more about it.
Hi, thanks for having me today and thanks for that introduction. All right, so a little bit about me. I still consider myself new to Canada, meaning that I joined the community back in only 2.5 years ago at this point. I'm coming from the US, where I was born and raised mostly in Chicago, but as I've heard from many Canadians, those of us who are American tend to move around a lot. So I've lived all over the U.S. and I'm now in Canada. And one of the reasons I came to Canada was to lead research and clinical programming around Black maternal mental health. And I always share with people that I had no way of knowing, or even, you don't know what you don't know. And until you know. So I had no way of knowing that there was no race-based data collection when I was asked to continue this effort that Women's College Hospital thankfully finds and has found very important to their vision. But when I got here, I was pretty shocked that, well, how are we going to help with Black maternal mental health if we're not capturing the data to really highlight where the needs are, to support the grants, to support the policies, and coming from the U.S. where these issues are definitely major. I'm very aware of what data can do and what lack of data can do as well. So I'll start. What this presentation is going to be about is really that journey in my time here in Canada thus far, and my efforts to characterize and capture and understand what is the Black experience as it relates to maternal mental health in Canada and Toronto and the Ontario province in particular. So what I see as the issue to some degree, and I'm sure people can add others, is that in Canada specifically, we have limited race-based data collection that has made it difficult to characterize our Black maternal mental health experience, the outcomes, the needs, what's the best treatment, what's the best intervention, what's the best prevention. And to start to address that, as an outsider, I came into the community meeting with the community. Well, what does the community feel? Because I didn't want to place my perspective on anyone. And I was being told by many that, oh, this isn't an issue. So I said, well, let me go to the community and see if it's an issue. So in conversations with 6 community organizations, and that's really a small group or a small smattering, I would say the 6 biggest organizations I met with, because I've met with many, many more organizations across my time here, but through 6 major organizations that serve the Black community, there was a resounding theme that there were concerns for disparities and requests for data to support resources. So I went anywhere from the midwifery groups to the Black doulas to some of the community health centers, discussing this and trying to better understand perspectives and if there was a need for further understanding and characterization and care. And as I continue to speak with people, the diverse community of patients, just everyone was saying we need more data, we need more help. So I determined that more research was needed to support any disparities, as has already been stated by Shâdé, establish preventative care and ensure optimal outcomes. All right, so just to highlight some of the background, why I even find this important, is that mental illness impacts as many as 20% of pregnant and postpartum people. So that's 1 in 5. You think, 5 people that have had a child, they likely have suffered with postpartum anxiety, depression, or some other psychiatric illness. We know that Black birthing people may be at higher risk of experiencing new or recurrent episodes of mental illness during pregnancy and postpartum, and are at risk for undertreatment of mental illnesses when they occur. Why? Because we are often not screened for mental illness. It goes unidentified. When there is treatment, there's not a lot of education or awareness around the options. There are cultural differences in approach to mental health and so on and so forth. So this really impacts our ability to get well, and this can leave us suffering in silence. So I set out to just even understand how we are managing this issue at Women's College Hospital, kind of just a local assessment, but also requesting their support to further look into the community, really building it on their mission and commitment to equity, stating that dismantling anti-Black racism and measuring what matters is what they're concerned about. And I felt like this project, as I'll share with you, looking at Black maternal mental health and identifying Black patients who are pregnant and postpartum was very much on par with the mission of the hospital and the mission of my work. So just highlighting, there are several prongs to the work I set out to do, and set out to do quality improvement in our psychiatry program at Women's College Hospital. I'll share some of my journey with that. I then set out to also get a provincial grant looking at data across Ontario for Black maternal mental health and obstetrical outcomes. And I've also set out to do things in the hospital to really capture our understanding of the Black experience, whether they're going through OB or psychiatry, and ideally where that overlaps. So to look at data locally, I started asking for demographic collection in our psychiatry department simply. Just can we understand who we're seeing, whether that's, whether it's race, ethnicity, sexuality. Those are some of the main gender, some of the main categories, and then, we can build that out even further. And I will tell you, I got a lot of pushback. People weren't comfortable asking about race. They weren't comfortable. They were comfortable asking pronouns, but not about sexuality. Which as a psychiatrist, I will tell you guys was very surprising to me, because I do believe that we are all trained very similarly, no matter where you come from. And part of our understanding and part of our assessment of the person in front of us is to understand the whole person and all the identities that they bring to that space. And at least that's how I was trained and how I've always practiced it. So we ask a lot of intrusive questions, trust me, about lots of other things. So race seems like a very low-hanging fruit, and as well as ethnicity, as well as sexuality. But again, being in a new land, I was, sensitive to the question, and have encouraged and tried to teach my colleagues how they might approach asking the question. The other thing we have set out to do is to just do interviews with the patients who are receiving care, who identify as Black, to better understand their experience. So just briefly, at just over a 3-month span, when I started this project back in 2023, we got some data from patients, and not many of them, first of all, we couldn't get all the data. So out of 348 patients, we could only really understand what was the demographic collection of 92 or 183 of them, and then 14 of those of 92 patients. So they're like, we kept breaking down in groups. So let me just go back again. So out of a total of 348 patients that presented over a 3-month period, we could only get data from 92 of the new consultations in terms of demographics. And of that 92, only 14 of them identified as Black. And my group was pretty pleased with this data. I was not, because I'm like, well, that doesn't tell us the entire group or enough about who we're serving and whether we're doing a good job or what's going on. But of this very small group, we understood that most of them were employed Canadian citizens and pregnant, and that about 43% of them had completed high school and completed college. So we got a little bit further into that social demographic collection. We got a little sense of where they lived in Ontario. The hospital implemented a sociodemographic questionnaire called We Ask Because We Care around the same time I was getting into this work in my department. And there's been an ongoing kind of push to maybe use this data instead of automating the collection of the department data, which I'm very close to getting done. We are crossing my fingers by the end of this year that will be in place. But We Ask Because We Care data, the challenge has been around governance and how do we use the data, who gets to use the data, who gets to see the data, and many of us can't access the data. And they gave me a report, and basically 42% of patients even respond to the data. So again, you can't really generalize or fully understand what's happening with the population when you're only getting a percentage of what's going on. With all of that going on in the background, I decided to pursue research provincially looking at the characterization of reproductive mental health among Black birthing Canadians, what I call the Black Hurricane study. And that was funded by CIHR in September of 2024. And through this, we were able to look at Black pregnant individuals, approximately 70,000 identified using the ancestry variable and the born information system. So thank you guys for that. And we're connecting that with ICES data. We're also looking, where possible, at Asian, Caucasian, First Nation, other unknown populations. And we've already got some great preliminary data coming from looking at outcomes coming from this data set, and hoping to publish that early in 2026. But first, we'll be meeting with the community to discuss the findings and see where we might go next, but also how the community is feeling about what we're finding thus far. Our data variables include psychiatric diagnoses, obstetrical outcomes, markers of severe mental illness, such as emergency care visits for psychiatric purposes, hospitalizations for psychiatric purposes, and suicides. So I keep asking, what does the future of Black maternal mental health look like? I welcome any questions at this point. I'm hoping that it's looking bright because we will have more data to understand and support and intervene and prevent.
Join me in welcoming Alexia Singh. Alexia is a registered midwife and clinical director at Ancestral Midwives. She is currently pursuing a Master of Science in Midwifery at McMaster University with a focus on culturally concordant care and its impact on reducing racial disparities in Black reproductive health. Alexia is passionate about advancing health literacy and creating equitable opportunities, particularly for Black and equity-deserving communities. She's ecstatic about being part of an innovative program and that aims to provide a truly holistic approach to Black perinatal health, and looks forward to supporting families through affirming and compassionate care. Alexia also contributes to the broader birthing community as a hospitalist at Oak Valley Health alongside Midwifery Unit, as well as professionally elected council member of the College of Midwives of Ontario. Alexia, thank you very much for being here today, and welcome.
Thank you so much for the lovely introduction. As mentioned, I'm Alexia Singh, Clinical Director at Ancestral Hands, and we're so happy to be here today to discuss how we're working to build trust and gather true experiences through the use of sociodemographic and social determinants of health data. So today's presentation will introduce AHM and discuss how and when sociodemographic and SDH data is collected and how it's used, and our vision for the future. Ancestral Hands Midwives, AHM for short, is an expanded midwifery care model program which allows for midwives to work in different ways than the typical midwifery practice group model in Ontario. This new way of working has allowed us to focus our program on the Black community and work to increase access to midwifery care. AHM was approved by Ontario Midwifery Program late in 2023, and we started seeing clients in February of 24. We're a B3 nonprofit organization. And unlike most other EMCMs, we're not directly associated with community health centers, hospitals, or midwifery practice group, but we do collaborate with all of these types of organizations. We're a small but mighty team of 3 and one administrator, and we look forward to growing our team and increasing our capacity. We're located in the Malvern area of Scarborough, and our catchment area includes parts of Durham, Scarborough, and York region. This program was created as part of the solution to the Black maternal health crisis because the high contact, low intervention care that midwives provide can lead to better perinatal outcomes and experiences. We can innovate in maternity care to provide the Black community with care responsive to their needs. This means providing culturally specific education and programming that's tailored to the needs of our diverse Black Canadian population. And we recognize the value in racially concordant spaces, and having midwives that represent our community has already been seen to make a huge impact on client satisfaction, especially as it pertains to advocacy and understanding and support. Many of our clients express a level of comfort at our clinic that they don't experience in other healthcare settings. For example, just yesterday, or a few days ago now, a client came into our office and she really just stopped by to take a nap. She went on to ask us to check something that she had talked to her doctor about, but she had felt dismissed. And things like this, experiences like this, are what illustrate how our clients feel in our space, and that assures us that we're headed in the right direction. As a first of its kind program, we're still evolving and we're figuring out the best model for meeting client needs. Currently, we provide prenatal and postpartum midwifery care. We see clients at any stage of pregnancy and work with midwives or obstetricians who provide intrapartum care for our clients as we're not currently conducting births. We're an intentionally low volume clinic because we want to ensure that we don't compromise quality over volume. And our visits are regularly an hour to an hour and a half long so that clients have an opportunity to speak, be heard, and have their needs met without feeling rushed. We have partnerships with local midwifery practice groups, one other EMCM in different communities to offer intrapartum care to our low-risk clients. And then we work with a handful of obstetricians to provide care to our high-risk clients or our low-risk clients who opt in for an who desire an obstetrician. We provide supportive care to clients who come to us already having a care provider but are looking for additional advocacy and support. And we work with other organizations such as Taibu Community Health Center and various perinatal care providers to help clients get the wraparound services that they need. Some of these services include primary health care, mental health support, doula care, housing, and legal support. And so we collect sociodemographic data with the goal of improving culturally safe, racially concordant perinatal care for the Black, African, and Caribbean community. We capture both quantitative and qualitative information so that we can reflect the client's real lived experiences. This allows us to tailor the care that we provide to their specific needs and also helps us determine how to prioritize care for equity deserving groups. Formally, we collect this data in a few ways. So first at the initial intake before care begins, and then again through the client experience survey after care is completed. To improve response rates, we often offer the survey at 4 to 6 weeks postpartum on our clinic iPad, and we also use program evaluation surveys for clients who attend our prenatal education and infant feeding classes. Informally, we gather qualitative data through Google reviews and client testimonies, which clients are invited to share if they wish. And these stories often provide depth and context that formal surveys can't always capture. So we use OceanMD as our platform for initial intakes. It connects to our EMR and allows easy access to client information, demographics, and social history. In terms of sociodemographic data, we ask about age, ethnicity, language, immigration status, income, and housing. And in terms of social determinants of health history, we want to know about clients' support systems, their mental health, substance use, safety, such as domestic violence concerns, and community resources that may be needed. And then we collect experiential data, which involves perceptions of cultural safety satisfaction with perceptions of cultural safety and satisfaction with current and previous care providers. Did they have a sense of belonging, or did they trust their providers? Did they feel safe? Where we're a bit stuck right now is, and where we need a bit more community input, is deciding what direction we want this data to take us in. What is most important for clients and their families, and how can we leverage this information to meet their needs and identify gaps? It's important that we don't assume that we know the answers, because as clinicians, we bring a very different lens to the population, the people that we serve. So what you see here are screenshots from our client feedback surveys. We provide this using a Microsoft form, which draws on validated tools from the Birthplace Lab. They allow us to collect quantitative data on how autonomous clients felt in their decision-making and how respected they felt throughout their care. What has been most surprising is how forthcoming clients are with their stories. Racial concordance plays a big role in this. So when people walk in and they see themselves reflected in the art on the wall, for example, they feel safe enough to share experiences that they've never disclosed to anyone, especially not even a healthcare provider. For me, this stands in stark contrast to other spaces that I've worked in, where Black clients rarely felt the same sense of safety and openness right off the bat. We use the data that we collect for prioritizing care, ensuring that we're serving our priority population, understanding who our priority population is and their intersectionalities, and we want to know what the needs are without making assumptions. We want our clients to know that they're seen and heard, so continuing to use participatory research methods to gather information together with our clients is really important. We want to use SD data to continue to create a safe space for clients to walk into, whether it's at our office or our partners' offices. And this means data can help to guide advocacy and training where it's lacking between all of our partners. And it builds a compelling case to increase funding for more midwives and programming that's focused on Black sexual and reproductive health care. This will allow us to increase access to care for equity-deserving groups and help to improve individual health literacy and hopefully expand to providing intrapartum care to our families that's in-house as opposed to working with other folks to provide that component of care. And it's imperative that what we do with the data does not compromise what we have already built. As you can see that we already know through existing qualitative data, clients value more time to build connection and trust, especially in a system that systematically excludes them from quality care. We're not trying to reinvent the wheel. There's already a strong body of evidence documenting the disparities that exist in the Black perinatal health, and we don't need to duplicate or reprove those findings within our setting. Instead, our focus is on making sure our research and key performance indicators truly reflect the priorities and the experiences of our community. So our vision is to use born sociodemographic and social determinants of health data to directly improve care. That means shaping programs and services so they're responsive and culturally relevant. It also means building a consumer steering committee so community voices guide how the data is interpreted and applied. And with this data, we can evaluate our impact, identify gaps, and compare outcomes for Black clients to other groups, highlighting disparities and advocating for equity. As well, the data can fuel research and knowledge translation that centers Black perinatal experiences. Currently, we use multiple platforms to collect data. So OceanMD, as mentioned before, Microsoft Forms, and manually with Excel spreadsheets. And while each tool serves a purpose, it can be time-consuming and it creates challenges when trying to integrate or analyze information across systems. So we hope that Born can help us move towards a centralized space for data collection. Having one streamlined system would make it easier to track sociodemographic and social health data, reduce duplication, and improve accuracy. It would also allow us to generate meaningful reports more efficiently, share insights across providers, and ultimately ensure that the data we're collecting is being translated into better care and outcomes for our clients and their families. But we also need to proceed with caution. And as Lana James reminds us, data governance matters. Who owns the data, who can access it, and who gets to publish it. We have to ask if the data could be sold, repurposed, or even used against the very communities it's meant to serve. And we need to be clear on our intent. Because historically, race-based data hasn't been mobilized to support Black communities. So without transparent governance and true community leadership, this work risks reinforcing inequities instead of dismantling them. We're really excited for what the future holds, and we think there's a lot that can come from collaboration and community. And so we're really excited to see where everything moves from here. Thank you so much for your time.
Welcome, Dr. Zenlea and Dr. Fierheller.
Thank you for having us. So my name is Dianne Fierheller, and I am a scientist at the Institute for Better Health at Trillium Health Partners. I've worked as a social worker in pediatrics at Sick Kids and Trillium for many, many years. And collecting sociodemographic data was part of my training as becoming a social worker many decades ago at TMU, was Ryerson at the time. And so really happy to be here. I'm going to let Ian introduce himself, but we're going to co-present these slides. So he'll do that next. We're here to share a little bit of our work and our story out of the region of Peel around building a learning healthcare community model for women's and children's health in Peel, really about laying the foundation. And so we're going to introduce our research program, which is called the Family and Child Health Initiative. I know we don't have a lot of time, so we're going to give snapshots. And then we're going to really focus on one of our projects, building a learning healthcare community model for women's and children's health. So quickly, I want to take a minute to acknowledge the land. This is the Credit River in the region of Peel, where our work is situated. And I want to acknowledge the treaty lands and territory of the Mississaugas of the Credit First Nation, recognizing the Anishinaabe, the Huron-Wendat, the Haudenosaunee, the Ojibwa-Chippewa peoples, and the Métis. And these are some disclosures on behalf of Dr. Ian Zenlea and potential conflicts of interest. And I really want to take a minute to acknowledge our amazing community partners. So we have a list of our Family and Child Health Initiative team. We are a community-based participatory research program out of the region of Peel at Trillium Health Partners. We could not do this work without our amazing community partners that we work alongside. And that includes organizations, it includes our public health systems, and the many children, youth, and families that we get to work alongside every day in our program. So I'm going to start. I know Alexia spoke about the importance of participatory research and community research, and I'm going to read one of the quotes from one of our amazing partners, Angela Carter from Roots Community Services. She is a leader that has been doing work in many different spaces in our region of Peel and beyond. And Angela says to us about community partners research, community partnered research isn't just about better outcomes, it's about justice. It's about saying to communities, you are not just a subject of study, you are a co-creator of knowledge, a holder of wisdom, and a vital part of any solution. As researchers, you have a beautiful opportunity. You can be the generation that does things differently, that leads with humility, builds with community, and centers equity at every step. The invitation is there. The question is, how will you respond? And I hope that we can all continue to think with these words as we move forward. A little bit about the Family and Child Health Initiative. We came together in 2018, really focused on how do we support the health and well-being of children, youth, and families and communities in the region of Peel. And for those of you that aren't familiar, the region of Peel consists of the city of Mississauga, the city of Brampton, and the town of Caledon. We want to deepen our understanding of the interconnected factors at the individual, family, institutional, and systems level that influence child, women, and family health. And we're really focused on action. We've heard from our community partners who we work so closely with that we don't want to do research that just sits on the shelf. So we're really intentional at co-designing, implementing, and evaluating interventions to support the health of children, women, and families in our communities. And this is just a little snapshot of how we do that. And so another one of our partners, Baldev Muda, said to us, academic institutions need to rethink how they do research in partnership with community agencies. And so a big part of our work with FCHI is part of my role as a social scientist. I sit on many different community response tables in our region. That's what these figures are showing here, some of those. And these are cross-sectoral partnership tables that are really focused on identifying the needs of communities and creating action plans together. And the work that we're about to present today really came out of work alongside the Anti-Black Racism and Systemic Discrimination Healthcare Collective. And this is a group that I co-lead in our region. And the conversation around data and the need for data really came to the forefront. There's been advocacy for decades, but really came to the forefront during COVID-19 when the region of Peel was very much impacted and multiple communities were impacted and there was no data. And so our community leaders really advocated with the region and with the ministry to really make sure that this moved forward. And the work that we're presenting today has really grown over the years from that work. So the project we're going to present today and some snapshot results, again, is building a learning healthcare community model within the Women's and Children's program at at Trillium Health Partners. And these objectives were to identify key partners and networks in maternal and child healthcare at Trillium Health Partners and across community services in Peel. We wanted to explore how community partners and healthcare providers can safely and efficiently collect and integrate individual level sociodemographic data. And we wanted to create a supportive environment for a learning health system by fostering partnerships and formalizing partner engagement. And I'm going to pass over to Ian now, who's going to dive in a little bit more to how we brought those objectives to life.
Thanks, Diane. Hi, everybody. I'm Dr. Ian Zenlea. I'm a pediatric endocrinologist and clinician scientist at Trillium Health Partners. I co-lead the Family and Child Health Initiative with Diane. We've been doing this work since 2018. You'll often see the two of us traveling together. We co-lead this program truly in partnership with our community and our other research staff. I'd also like to acknowledge that Sarah Abdullah, who is one of our team members, is also present on this webinar. Sarah led this work alongside me and Diane in the Women's and Children's program at Trillium Health Partners. So many of you may know that the Women's and Children's program at Trillium Health Partners is going through some significant changes. We are consolidating all of our inpatient acute care programming to the Credit Valley Hospital on October 8th. And this is a stepping stone from a multi-site system of care for women's and children's to still a large system of care, but moving towards our future Shaw Family Hospital for Women and Children, which will be opening in the early 2030s. And that Women and Children's Hospital will be situated within a larger Peter Gilgan Mississauga Hospital that will be about 22 stories high, one of the largest hospitals I understand in all of North America, at the current Mississauga Hospital site in Queensway. Our research institute, the Institute for Better Health, does work in learning health systems. And for those of you who aren't familiar with the learning health system, it's a healthcare framework that continuously integrates clinical data, research, and practice to improve patient care and health outcomes. It promotes a cycle of gathering data from routine healthcare experiences, analyzing it to generate insights, and applies those insights to make evidence-based improvements in real time. And our institution has conceptualized a learning health system as an engine with gears, with fuel and accelerants, and with moderators and brakes. And you can see that the key features of a learning health system include data-driven decision-making, continuous learning, collaboration with clinicians, researchers, people with lived experience who utilize health services, who we refer to as service users during this presentation, policymakers, all in shared learning opportunities and rapid implementation. So Diane has used the term learning healthcare community, which is the title of our project. And a learning healthcare community essentially extends the learning health system by fostering broader collaboration and partner engagement beyond just healthcare providers and researchers. This model emphasizes the inclusion of people with lived experience, children, youth, and families, community organizations, and policymakers in the learning process. So really extending outside, sorry, I have a puppy in the room and he is getting agitated. Broader data inclusion, localized innovation, sustainable improvement, and enhanced collaborations. So essentially, the learning healthcare community is a model that we're really endeavoring to build at the Women's and Children's program at Trillium Health Partners, and within this new hospital as we're laying the foundations for that. So this project that we're presenting today is part of a broader initiative within Trillium Health Partners to consider the opportunities for us to collect sociodemographic and social determinants of health data across the institution in partnership with our community. Diane and I had done some foundational work a few years ago through some funding that we received from the University of Toronto, where we engaged community providers in understanding who is and who isn't accessing primary care services in Peel. And through that work, we learned that many of our community agencies, who are primarily social services agencies, are already collecting sociodemographic data and data related to the social determinants of health. So we brought that thinking into the organization as our data governance committees, our digital health committee are thinking about how we, as an EPIC institution, that is our electronic health record, might start to use EPIC and the features within EPIC to collect data within our population health modules. Rather than just turning something on within a computer system, we really wanted to engage our broader community partners who've been doing this work in the community well for decades, and then our service users within our system, both outside and inside the walls of Trillium Health Partners, and then our service providers to understand what some of their values, needs, and preferences might be related to the collection of these data. We wanted to do this slowly, intentionally, and aligned with our principles around community engagement and community participation, which Dianne spoke to. And so we have conducted this work in 2 phases. The first phase was the foundational phase, during which we really engaged community partners in a series of workshops, and also community service users in these workshops to identify the key priorities for sociodemographic and social determinants of health data. We analyzed the results. We prepared a community report, and Dianne can put the link to the community report in the chat for all of you to see. And then we wanted, after taking this community approach and this community lens, to bring that thinking into the walls of Trillium Health Partners, and specifically within the Women's and Children's Program. And we identified 4 key areas for engagement, thinking through planned care being outpatient clinical opportunities and unplanned care being acute care inpatient opportunities, for how we might collect these information safely, meaningfully, honoring community needs and values, really respecting privacy, confidentiality, and understanding what the needs from an educational perspective and capacity building perspective of our providers might be, and how we might start to engage our service users in understanding the reasons why we might be collecting these data. And this is work that we conducted within the new year from January to June of 2025. And through all of this work, we've actually engaged through the course of this project over 160 people. Those have included 35 service users, 50 service users, so people with lived experience, 53 social service agencies, 55 THP clinicians and administrators, THP being Trillium Health Partners. We've engaged 10 municipal and regional employees and 9 other medical providers and administrators. And so all of this information has been distilled down for the first time, for the first phase in that community report. And then we are preparing a THP focused slide deck that we'll also use to share our results. And so what we've learned is that some of the key foundational elements that emerge through the qualitative analysis of these workshops is that it is critically important and really foundational, hence our naming this the foundational phase, that we intentionally work to build trust and transparency with our community, that we think about institutional and logistical factors that impact data collection. So really thinking about the timing of data collection, when is it appropriate to ask some of these data elements, who should be asking, what training they should have in order to be comfortable asking, and what education we might need to provide our service users so they feel comfortable and they're building trust with our providers to share some of this information related to their social determinants of health and sociodemographic factors. And that it's important that these data are actionable, that they are not specifically used just for the purposes of research, that they actually inform the care that's provided. And we've heard a lot of exciting conversations so far about care provision and how these data can inform that. Some of the key elements that we wanted to prioritize would be race and ethnicity, language, religion, disability status, and gender identity. Some of our THP focused workshop themes included addressing communication barriers, so thinking about language, thinking about how we might leverage EPIC and specifically the MyChart function, which is the patient portal or people portal, which can also collect patient reported outcome and experience data, how we can continue to build trust and continuity of care with our service users. It's important that we avoid assumptions, so we shouldn't just assume something about the people we're serving, and people don't want to have assumptions made about them. We really need to intentionally ask and create that safe space for that to happen. And really, most importantly, that we prioritize trauma-informed and patient-centered approaches. So some of the recommendations that emerge from this work is that we collect data as much as possible before care so that it can inform care. And this would be more of an asynchronous data collection opportunity with data collected in advance of a planned outpatient clinical appointment, that any data provided should be voluntary and optional, that data collected before care should include multiple choice options and then open-ended questions, that there should be those sort of structured and unstructured data fields, that in-person data collection should be in a safe private setting with the choice to provide verbally or in writing, that we collect data only one time and share this across teams to avoid repetition. And we can do that within our hospital through our integrated health system, When we talk about bridging into the community, that's where it's more challenging given the disparate systems that don't communicate effectively with each other. And that it's important to consider how the data being collected, how it's collected as opposed to who is collecting the data. So it's how is just as important as the who. The who was really anyone who was meaningfully involved in that clinical care encounter, and the how really was through the multiple opportunities in using the trauma-informed approach. So in our organization, we're now going to be focusing on acting out these findings. So we did a deep dive into this one inpatient area, which is our labor assessment unit. And we did a deep dive through interviews and patient journey mapping in 3 outpatient clinical areas. One is an extended midwifery care program. One is a developmental disability serving program for children and adults. And the other program involves family violence and intimate partner violence. And so we will be in the next few months planning to actually implement the pilot data collection opportunity in partnership with our teams in Women's and Children's and our digital health committee and EPIC teams. Okay, I think that I did that and my dog did not interrupt, so I am finished. Thank you all again for your patience.